Thanks, Eleni, for that kind introduction. And really nice to be with all of you in this room, and really great to be contributing to this workshop again this year. My talk will be about providing you a quick snapshot of what we see coming after following the 2021 guidelines that were launched last year. And I'll do that by taking you through some updates in terms of guidelines implementation, some aspects that may provide some potential for policy revision in the near future, and then flag a few remaining research gaps that will be important to address. But before I do that, I want to note that there's also guidelines document that are being launched and have just been launched. And that will be launched at this conference. The first one that is already out there is the update on cryptococcal meningitis management that was out a few weeks ago. And then later in the week, you will hear more about our new guidelines on strategic information, CAB-LA, that of course is of great interest to many colleagues here, and then key population guidelines as well. So I would really invite you to join WHO events on the 29th to really hear more about these pieces that will be presented more officially to at the conference. So let me now start with reviewing a bit quickly with you and with the contribution of a lot of colleagues in the treatment and care team at WHO, how implementation of 2021 guidelines are going. So I'll start from the hot topic of scaling up pediatric dolutegravir, which we know it's something of great interest, introducing guidelines in 2018, but only last year we were actually able to implement pediatric dolutegravir from 4 weeks and 3 kilos. Now, the type of information we are receiving from countries that you see summarized in that map are still a little bit patchy. But I think what is important to note is that as of today, about 45 countries have purchased pediatric dolutegravir, which means that even if they haven't included it in guidelines or are not implementing it yet, that's the direction. And that's a really important message. I think considering a global pandemic for the last 2 years and considering the struggle that we've had in the past, I think it's fair to say that introduction of dolutegravir has been much more rapid than before. There's been certainly high level of acceptability of the new formulations that have been introduced. And as we've seen from Mary's presentation as well, we are observing really good virological response in multiple countries. So a lot to be positive and hopeful about. But we know that there are still remaining challenges, and some of those relate to the fact that transitioning to dolutegravir when you have complex treatment history is not necessarily easy. We also know that we need to ensure that children that cannot take dolutegravir can have access to appropriate formulations that might not always be readily available, particularly for the small population that might require it. So something obviously to really keep in mind. Certainly there is more that we can do better. We can better monitor treatment outcomes. We can include the community much more. We know that if there is someone that needs to be thanked for the rapid introduction of dolutegravir, that's the community that has already gotten involved with all of that, and that's certainly important to build on. But one element that I want to flag today, it's really the challenge with ensuring access to dolutegravir globally, more globally. And we often talk about sub-Saharan Africa because rightly so, the largest burden of the disease is there. However, there are important challenges to access dolutegravir in many other regions of the world. So I wanted to zoom in today a little bit on that. And note, for example, that in the PAHO region, even though you see that the map still presents some gaps, there is an important mechanism, which is the PAHO Strategic Fund, that is really playing an important role in scaling up pediatric dolutegravir more broadly. And so you will see that figure to change very quickly over the next few months. In contrast, we see in the Western Pacific and in the Southeast Asia regions still important challenges with registration and access to pediatric dolutegravir in many, many countries. And even in India, where some of these generic formulations are being developed, we know that dolutegravir is included in guidelines, is actually being registered, but yet not implemented. So a lot of work that needs to be happening in these regions, and I think that us as global partners and experts, we really need to be vocal about this, and we need to be able to see where we can help and provide support. And that's similar in the European region, where I think some of these challenges have been brought up, particularly by the Ukrainian crisis. And I think that, unfortunately, you're all very familiar with the challenges that the population in Ukraine is facing. And we know that there is about 2,700 children that are living with HIV in Ukraine that require care. And we know that there's been important disruption of essential health services in the country. But one good thing that happened through that difficult time, and despite the difficult time, is that the government has decided to really optimize pediatric treatment and move away from the lopinavir-ritonavir syrup for young children to pediatric dolutegravir. And that was possible thanks to donation programs and support that many partners have provided. Now, the challenge with that, though, is that the majority of children, Ukrainian children living with HIV, have been displaced in neighboring countries. And therefore, we know that many countries, some of you are from those countries, are providing support and showing great solidarity to those kids. But some of the benefits and advantages of, some of the regulations that have been put in place in Ukraine to facilitate introduction of dolutegravir do not necessarily apply to the neighboring countries. So in fact, there are challenges with pricing and access in those countries that we need to be mindful of, and those elements actually still challenge the provision of dolutegravir in those kids that are now in the European region and receiving care in multiple countries. So something that obviously requires still the support of multiple global partners, and something that we're all very committed, I think, to assist with. Now, let me transition to infant diagnosis and point of care. As you know, the recommendation on point of care was another new piece, strong piece of the 2021 guidelines, one for which we don't have a very clear picture in terms of rollout, at least yet. But what we are seeing from work, for example, that our colleagues at CHAI are doing, is a very clear trend towards scale-up of point of care. There are challenges remaining. Obviously, the small market side, the costs, and the suboptimal pricing models are a problem, and that it is really potentially could jeopardize the full scale-up of point of care in the future. So something to really look at. And on the ground, we know that under-resourced primary health facilities prevent us to actually decentralize point of care to the extent that we would like to do. So clearly more work to be done on this front. But I think that it's important we put it in the context of the greater, of the bigger picture for infant diagnosis and infant testing. I think Mary has already alluded to the need to really identify those kids that are still not on treatment. We know we're doing somehow better compared to the past with infant diagnosis, at least on the 6 weeks testing. But clearly there are remaining challenges that we continue to face with. There are the usual ones. Competing priorities, retesting at the right time, and then turnaround time when we don't have point of care. So there is more that we need to do, and I think we need to obviously focus on final diagnosis, better integrate services across the cascade, and then be able to really work with the community to really reach those kids that, as Mary was saying, we're not able to identify because they don't come to the facility, they're not sick, and those are the ones that we need to reach in a different way. Now, another element that has been absolutely important to us at WHO and many partners is differentiated service delivery models. And this map shows the uptake of frequency of ART pickup for people who are established on ART. This is across populations. So as you can see, it's a pretty encouraging picture. And I think that it's fair to say that we've seen great progress in the pediatric population as well. But it's important we remember that multi-month dispensing is not the only thing we have for DSD, and therefore particularly elements related, for example, to peer support needs to be scaled up, and that is happening already very well in the adolescent population through mentor partners programs, but it's something that we can really capitalize on. One of the challenges we're facing with DSD is that there is still some it's a little bit difficult to align what is the need of the caretaker and what is the need of the child. And so how we see DSD more in the context of the family, but also how do we start ART outside of the facility? That's something we don't have a lot of experience with in pediatrics, and that's something that requires further piloting and documentation for people to actually do more of. We know that has impact on supply chain, and that's obviously something that people in programs that are more involved with commodities obviously have a particular interest on. clearly, we need to build on the community. We need to be able to deliver more services through the community and therefore outside of the facility services. And we also need to be able to monitor. I feel like many of you probably agree that there is a lot that is happening already on DSD, but maybe we're not able to document it in a way that actually helps and informs our global policies. So I'll now transition into perhaps discussing a little bit more what are the areas for potential policy revision on the horizon. And I'll start from the ARV sequencing, because I think we all appreciate how having better drugs, more tolerated drugs, really helps us to potentially relook at the public health approach and refresh it to make sure that we put it more in the context of what we have available now. And that might mean, in some cases, to challenge the core principles that we've used for ART sequencing. And I think that one of the things that certainly in the near future we're going to look at is provide greater clarity on the single drug substitution or recycling of NRTI backbone. Many of you know that there was important evidence shared at CROI in the adult population that is quite reassuring in that sense, but how much can we extrapolate from that to children? We know it can be challenging. Then related to that, we anticipate to revise the second and third line regimens as well, and also the entire concept of second and third line perhaps, because we know that in a context of very complex treatment histories, is very, having first, second and third line may not mean that much anymore. And so there is certainly a desire to kind of relook at all of that and see if now our next guidelines can actually capture these nuances. Genotyping is really not part of the public health approach, but it's clear that some countries are using more genotyping, and we think that our policies in the future will have to at least support and guide countries in being able to use genotyping in the context of the public health approach. We also know that many countries, some countries globally are adopting dual regimens, and this is something that I want to note is not part of what we anticipate to change in our guidelines. Our expert review committees have already noted how dual regimen have little added value unless we actually use long-acting medications, and we know that we don't have the right combination yet with that. So a little bit further in the future, perhaps. Now, another element that we're really trying to innovate is postnatal prophylaxis, and I'm sure we'll talk about that during the course of the workshop. We've started to take baby steps because we already have supporting language that potentially allow for use of legacy ARVs in the case of stockout on a European AZT. We also know that some countries have gone ahead and have used enhanced prophylaxis, extended prophylaxis approaches, but monitoring those approaches is going to be essential for us to be able to change policies, because otherwise it's going to be extremely difficult. There is a sense of alignment, that alignment between treatment and prevention on ARVs will be advantageous, particularly for programs. And we also have a sense that at least for perinatal transmission, extrapolation of efficacy from ARVs approved for treatment might be appropriate. So in fact, what we need to change guidelines here is really to have more information about the safety of these alternative approaches used in countries, and something that we hope countries and colleagues that are working in countries will help us to consider. The other element that I wanted to note is that something that we took very seriously in 2021 in WHO was the use of cotrimoxazole in HIV-exposed infants. And we went back to the evidence. This is a systematic review that was looked at. We brought together an expert group. We assessed some modeling scenarios. And together, we really looked at two key important trials that undertaken in Botswana and South Africa that showed lack of clinical benefit for children that are HIV exposed but uninfected. Now, as a result of that, we developed this implementation consideration that you can see here in the slide that is currently in the guidelines and that already allow countries that have low vertical transmission rates, high HIV infant diagnosis coverage, and strong retention in the testing to treatment cascade to actually have alternative approaches to cotrimox use and perhaps use it just in children that are diagnosed with HIV, which is what I understand is the direction of South Africa. So we anticipate that over the next couple of years, as lower vertical transmission is documented, higher EID coverage is achieved, and there's more experience with these alternative approaches, then we can consider a number of alternative options that could go from interrupting cotrimoxazole when a child is identified as negative all the way to starting cotrimoxazole when that child is identified as positive. So something that we need to look at. And then something that we don't anticipate to change, but that might result into a shift in the focus, it's really early testing and early treatment. We know the recommendations are there. The critical time points for when to undertake virological suppression and starting treatment early are there, so we're not changing anything. But it's fair to say that right now, the focus is on the 6 weeks and the 9 months. Now, as we have more evidence generated on the benefit of very early ART, and as we are potentially able to use either lopinavir or dolutegravir or both in neonates, and perhaps even have more extended approaches to postnatal prophylaxis, perhaps the shift and there needs to be a greater attention to birth testing with point of care so that we can start as early as possible with the drugs that we have and then be able to strengthen the mechanism and the system to be able to make sure that we can undertake final diagnosis at the end of the at-risk period. So again, no new recommendation, just perhaps a little nuance for implementation. Now, I'm going to finish off my presentation with touching on a few key research gaps. You all know that together with CIPHER, we developed a very thorough, comprehensive research prioritization exercise that many of you contributed to across treatment, prevention, and service delivery, and testing, sorry. And that was for children and for adolescents. So all of those priorities are still very valid, but I wanted to just flag a few elements for your consideration, because I do think we need to do more work in investigating how we integrate HIV services into the maternal child health platform. That is not clear yet. And I think we always talk about it, but perhaps there is more implementation research that needs to be undertaken to inform our policies. And also psychosocial support and family support, that's something that I don't think that it's been documented to the extent that is required for us to update and make stronger policies attached to that. And one element is also related to sexual and reproductive health outcomes, as well as support to pregnant adolescents. There's a lot of work that is happening on the ground. I know colleagues in UNICEF are doing fantastic work with countries in sub-Saharan Africa, but there is more that needs to be gathered so that we can change policies and we can update them. On the treatment side, I want to in particular flag the co-infection aspects, and in particular the fact that, yes, we have an advanced HIV disease package, but that advanced HIV disease package has been largely extrapolated from the adult data. And what we need is more research that helps us to refine that package for the younger ones, understand better what are the exact components that need to be included there. And I want to close by noting the conclusion of an important series of meetings called CADO and PADO that really speak to the drug optimization agenda and how we can better target research and development for the future. And really share with you that, as you can see, there is a number of new priorities that have been identified both for adults and for children. In particular, for children, I want to flag the inclusion of CAB-LA as one of the priority products to be investigated for postnatal prophylaxis. But I think in general, what these two meetings told us is that, and emphasizes the need to really think about new ways to deliver medicines to children and be able to find the immediate opportunity to test those new methodologies, also and think about them in the context of the new service delivery models that we anticipate for the future. And then important to explore approaches that might be simple for the program, but even if a little bit disaligned with some of the core principles I was noting earlier, so a little bit out of the box thinking. And also how we reconcile the core principles of the public health approach with the need to perhaps have a more centered view on the patient and perhaps provide more choice. So how do we balance these aspects is something that obviously we'll have to think about. And as we do so, how we innovate our methodologies to investigate new treatment options and new preventive options. How can we shift from the standard clinical trials that are very resource intensive and take a lot of time? How can we use better observational data to be able to fill the research gap that we need? Ultimately, the long-term safety and effectiveness of HIV agents is going to be critical, and that's one that we need to keep really on our horizon. So I just want to conclude by noting that clearly there is significant progress that is happening on some core components of the pediatric and adolescent program. And what we need to do is build on what is working well already. And we need to do that to tackle the difficult parts, the parts that we keep struggling with, the testing part that Mary mentioned earlier, but also to try to bring the community more actively involved across the spectrum of intervention that we need to provide to children. There's clearly a few important anticipated revision and WHO guidelines that may bring novel view both on the sequencing as well as the care that we provide to HIV-exposed infants. And there are research gaps that persist. As you can see, they're largely on the service delivery side. So again, implementation science is extremely needed still. So as we tackle the how-to with that type of research, I think it's also important we start thinking about bold ideas that we want to start testing so that we can imagine how treatment and care for children and adolescents in 10 years' time could look like, and really be able to really put our strong roots on the ground and the work that is happening that many of you are leading on in countries, but also think a little bit about the longer term and come up with some of the more innovative approaches that may really transform the way we take care of children and adolescents. I'll close there and thank all my colleagues in the treatment and care team for their contribution to this presentation.
Well, I'm sure everybody would like to interrogate all these interesting data, but unfortunately we're out of time. I'm going to commit Mary and Martina, though, to be available to everyone at the coffee break, because I'm sure there are lots and lots of questions. We can take 5 minutes? Oh. Oh, I have the wrong time. Okay, great. So, how are we doing questions in the room, Karen? So raise your hand if you have questions, and I'll just start with one of the questions that we've gotten from Anthony online. And thanks to Dr. Mary, PrEP for pregnant and breastfeeding women has potential. Do we have systematic global or regional data on uptake and continuation of PrEP in this subpopulation, pregnant and breastfeeding women?
Thanks for the question. It's a great one. We are seeing remarkable upswings in the number of people on PrEP, but we don't have that categorized currently by pregnancy and breastfeeding. It's requested for countries to submit that data by those breakdowns, but we have not received enough data to kind of summarize it. I think for the future, maybe we look at some country examples and try to present those as showing what's happening, at least in those limited settings. But it's a great point and one that we'll keep following. Thanks.
I think it's hard to collect those data, yeah. So let's do 1, 2, 3 for questions. Please introduce yourself.
Good morning. My name is Eleni Colt, and I work at Ministry of Health, Mozambique. I have questions first for Mary. My first question, Mary, how does the Spectrum platform is predicting those children that are aging, but we are not counting them? Because what we see on those of limited paper-based is very difficult to count those children that, like my country, that are growing up, but we are not taking them out. So how UNAIDS is predicting to do something that inside the spectrum so we can count those children, because we know that is not possible when we don't have electronic systems to move on. And when the paper-based is very difficult to move on. I saw you very interesting say that potential things that we can do, and we talk about PrEP. PrEP is new, yes, it's good, but we see challenges in the ground. One of the challenges that we're seeing that people don't want to be connected with those ARVs. They're saying, why can I have to take drugs when I'm not sick? Why I have to take drugs that is same that as HIV positive people are having? So how do you tackle those things? What we are thinking about as a UNAIDS to really have as a communicating people how important it is, but at the same time, people are they are not coming back. They are taking the first month, they are not coming back to pick up. We give in 3 months, they are not coming on third month to pick up. So we have those challenges. It's a potential, but we are struggling in countries. For Martina, we saw that we want to research in terms of service delivery, doing research on that. I think it's important that has to be done, and it has to be done fast. Because we are talking about multi-month dispensing for pregnant women, lactant women, but what we are seeing that we are really having a fight with MCH people because they are saying that how can we have this balance? We want better outcomes for HIV, but we are putting things, how do you say in English? But we are leaving MCH behind. So we are not like having the balance to have the better outcomes for HIV and also for MCH. Okay. So how do we balance this? We have to do this research, but how do we balance that?
So, we need to give them a chance to answer these questions.
That's my last one, Mary.
No, that's 3 already. So,
okay, fine.
Okay. So Mary, and then I think maybe Martina, you want to weigh in on the second one, the last one.
Yeah. So thanks. Just to say, so agree very much with the concern about how do we watch children aging out. So what's nice about Spectrum, the software that we use to estimate, to make these estimates, is that it's got a full demographic backbone to it. So it's watching how children transition. It's keeping those denominators correct to say, no, these children are turning 15. We're no longer classifying them as children. But what's so critical is that the programs have that linkage. And so that the clinic that is helping pediatric children is also being able to link directly to the adult treatment. And that transition is different in every country. And so the models have it. The models can give you an output. Spectrum model gives you an output, how many children are turning 15 that are living with HIV, so that you can quickly look at that and recognize what is an aging out versus what is some other impact in your model. But the important piece there is your clinical data and how you manage that clinical data going from 14 to 15. The second question about PrEP is critical. I think in our global report that's being launched today, we talk a lot about what happens with PrEP and how it is some young women want nothing to do with PrEP because that's associated with being HIV positive. I think there's a lot going on in terms of understanding the operational research of how do we provide it, one, in a different mode of a different modality so that women can take it in different ways, but also to think about how do we reduce the stigma on it to somehow allow these women not to be afraid to have those medicines in their hands. And I'll stop there.
Yeah, a quick comment on that last question, and which I think was also a comment from your part. I think that it was related to the conflict, or at least perceived conflict, between the HIV program and the MCH when it comes to delivering services and particularly differentiated care, I think. And that's why I think that, operational research is so critical, because until we actually collect data that can be compelling to really, help various parts of the program in the HIV program and outside of the HIV program to actually come together and see how, in fact, these type of differentiated service delivery can be implemented with a positive impact on outcomes, I think there's always going to be that tension a little bit. Our policies are supportive of the MCH, postnatal, for example, the postnatal services to continue as they are supposed to continue, and then simply the HIV services to be delivered through DSD models. So they're not in conflict, they can coexist, but we know that sometimes that's difficult to articulate, and certainly on a country level, like people like yourself that are leading the entire program and that are really designing all of this, it's challenging. So I really think that collecting data in those places where this has worked would be really essential, because that will help us to make stronger policies, but also help you to really advocate for some of these changes to happen.
Richard?
Hi, Grace John Stewart from University of Washington. Thanks for the great presentations. I just had a related question, somewhat to what has been previously asked. With EMTCT, there were very clear targets for programs in order to know how they were doing. And I was wondering if there's thoughts on how to help programs align their targets for PrEP. I know that the denominator is a problem, but if there's a way for programs to know that they're on the right track, other than the stacked bar graph that tells us when we've failed, is there something that can help EMTCT in terms of that target? And related to that, how are people thinking in terms of triple elimination? I didn't hear about that. Just your comments on that.
Just quickly on the EMTCT and the PrEP targets. So we're working quite a bit with developing methods for developing PrEP targets within countries. Within that, we're focusing on key populations and not necessarily on the pregnant and breastfeeding women, from what I know of that process. But I just think that's an important question, maybe one that we could be bringing into the global level for, as we work with countries, how do we help them develop that? So it's a great idea. That's my short response. Yes. Thank you. in the triple elimination, I don't have much data. I don't know if you want to speak to this. I don't have much data coming in on the hepatitis and STI. I think that would be more in WHO.
Yes, so I would really like to perhaps address that. We have a colleague, Morko Newman, who's leading all of that work that will join us soon, and I'd like for her to provide more details. I mean, it's an important process that is really tackling various countries at the same time. I think the road to elimination and the path to elimination in sub-Saharan Africa is obviously a whole different business. We've heard about Botswana and the great progress that's been made. There's certainly ongoing conversation to have that happening in other countries, but I can't provide more details on that point. I would rather have her to tell you a little bit more about that.
So before going to 3, I'm going to take one more virtual question from someone named Annette. Dr. May, the drop-off in PMT-CT coverage in Asia-Pacific region over the last 2 years exacerbated a pre-existing gap with the global rate. Can you or Dr. Penazzato comment on what the persistent barriers are to scale up in these low prevalence settings?
I'm trying to think quickly on the data coming from, so Asia Pacific does, it's shocking, and in fact, I looked at it yesterday because I was so surprised why in Asia Pacific is this so hard to be closing these gaps. And as many of you know, the major influencers in that region is going to be India and China, both of them showing treatment coverage, PMT-CT coverage somewhere in the 60s and 70s, and I don't have it right on the tip of my tongue, but with those consistently low values, as well as with countries like Pakistan, Philippines, Papua New Guinea, with very quickly increasing epidemics, we have a lot of new infections happening, and thus we have a lot of pregnant women living with HIV that are not necessarily on services. And so with those challenges, I think is the reason we're getting such coverage rates that are so far behind the other regions and are actually bringing some of the global levels down. This was one of the first years that we've actually published, or not one of the first years, first time in like 3 years that we've published India data, because we've never been on the right timeline with them, but we're really grateful for them for supplying that data, and we think it's important for understanding what's happening in that region overall. But Annette, it's a great question, one that we'd be happy to work with more people in Asia to try to understand and to dive into. Thanks.
Fantastic. Okay, let's go to 3.
Hi, my name is Mercy Shabemba. I'm part of the team at Penta in the youth engagement team. And I've also lived with HIV my whole life. And my question was about differentiated service delivery. It made me really happy to hear you say that it's not just about distributing medicines at different times, but also really sad that we're still having to say that in 2022. My question is, why do you think that the message has not yet cut through for children and differentiated service delivery? And what are we going to do to platform the voices of children and young people so that that message can cut through to funders, policymakers, and healthcare practitioners?
Mm-hmm. Well, I think you would be a great voice, and many of adolescents living with HIV and young people living with HIV that have gone through all of that can be an important voice for us to really draw more attention to this issue. I think the challenge with DSD in pediatrics is that it's more complicated in a way, right? It's more than just ask patient how would you like to receive your care? You're doing well. Would you like to receive it like outside of the facility? How often do you want to come back here? I think we know that for children that's different, and dynamic within the family is different. And I think that perhaps there's been a bit of, we've been all a bit cautious also, right? Because I think we've been, we have stuck in our heads so many stories of kids that progress very quickly, that had the wrong treatment or that we weren't able to save, that I think for healthcare workers that are on the ground, it can be quite difficult for people to say, okay, well now let's change our approach, let's make it different. And I think that that's the other perhaps message that we need to try to turn around and just really speak about the positive stories that can happen, the way that we can deliver services to children in a way that ensures that they can really reach outcomes. And then, again, just put forward that positive messaging, because I think that's more powerful than, right, just keeping and trying to you know, speak up and speak our, just raise our voice. I think that story, that narrative can be, of course, it needs to be coupled with experience, with exact examples of how things can be done. But I think I know of partners like ECPAF, ICAP, and many others have really modeled and have piloted a number of DSD models for children and adolescents that, you know, work really well. So we need to just make sure they're disseminated, they're shared, and the multiple countries can really, you know, learn from each other and then scale up their efforts.
Okay. There's one last question, and then we'll close the session.
No, thank you.
A quick question.
Chair, I just wanted to contribute to the conversation on low prevalence countries and what we need to do there and what we're seeing in terms of declines in coverage. We're actually looking at that work together with WHO and trying to look at what the issues are. And I can probably cluster them into three. One is political will. Two is, what is the program design that would work for those countries? And then how do you bridge what's happening in MCH? Because some of these countries have very good coverage of prenatal care, postnatal care, especially in Asia. But when it comes to HIV, the integration is not happening. And then you have countries like Congo. There are a lot of countries in Africa that are low prevalence, but the issue there is that the MCH also is problematic. So we really need to unpack some of that. And so part of this is what makes economic sense in terms of program design. Are we saying we test everywhere? Are we saying we test and link? And what would that look like? The good news, though, is that most of the countries that have been validated for elimination are low prevalence countries. Correct that some of these are territories with very low population levels, but still, what can we learn from those? And I think it's really a marriage between the politics of this and the financing of, and the good and the will. If you look at Thailand, the intention was always there for them to expand primary health care and make sure that they have a package of services that also works for HIV. So I think it's work to be done, and I think we all need to look at what are the differentiated models we are supporting and promoting there to make sense, including integrating HIV, syphilis, and hepatitis. What does that mean? Over. Thank you.
Cherry, it sounds to me like you're also talking about sort of precision public health in a way, really drilling down to specific countries and even beyond that. Okay. Well, I want to thank our speakers and thank the audience for a fantastic session.